So welcome to everyone to the ACCCN Institute of Continuing Education webinar series. For those of you who don't know me, I'm Dr. Diane Chamberlain and I'm the ACCCN Global Sepsis Alliance representative. I'm also Associate Professor in Critical Care Studies at Flinders Uni and the National President of ACCCN. The Global Sepsis Alliance, I'll just give you a little rundown on that while we're waiting for others to join us, has a goal of early recognition of sepsis, and it's funded by donations all around the world. And this year the aim is to have the sepsis recognised as a diagnosis in the burden of disease report, and that the World Health Organisation publishes, and some of you may be aware of that. But unless we have proper definitions for sepsis, we can't actually categorise it properly for funding or for recognition in health systems and in public health. So the work here in the new definitions will start that process. So today I present to you the new sepsis definition, Sepsis 3. I'll be talking for about 30 minutes. Then I'll do my best to answer any questions. So please hold them over until then and type them in the chat box, and then we can look at them all together. I'll just remind you that we're recording this webinar and that anything that you write will be recorded, and if you later that you want it deleted, please let me know. So what I'll do is I'm going to go to my screen, and while we're waiting for a few more people to come, and I can see Jill there's typing, I'll want to advertise the World Sepsis Day, which is in the 13th of September 2016. Each year there's a World Sepsis Day. And we celebrate it in various ways, usually just having education sessions and awareness sessions here in Australia. But in Europe they actually hold, governments hold big celebrations out in public areas, in public arenas. But here in Australia we don't tend to do that quite as much. But if you're looking for something to do, and we may do this through the ACCCN, is to have a pink picnic day. And we can do some fundraising for World Sepsis Day fundraising event. So it could be something you could do in your unit or with your workplace, have a morning tea to do some fundraising for World Sepsis Day. Okay, so I'll continue on now with the webinar, and if you could hold your questions over till later, that would be good. Okay, so I'm just going to bring up my PowerPoint here, and we'll take it from the top. Okay, so it's my pleasure, as I said, to present to you the new sepsis definition, Sepsis 3. And today we'll be having a look at the definitions, the work up to it. We'll re-examine SIRS, looking at the new definitions, the limitations probably of the new definitions, and how we apply these new definitions to clinical practice. So here is the document, the third International Consensus Definitions for Sepsis and Septic Shock, Sepsis 3, so it's called now. And this was uploaded to JAMA, which is the Journal of American Medical Association, on the 23rd of February. In fact, there was a lot of us who are heavily involved in sepsis who were waiting with bated breath for this to be uploaded. And in Australia, we actually had to wait until the wee small hours of the morning to see the publication unveiled. And then the Twitter feed went absolutely berserk for several hours and took several days to subside. So it was a historic and significant moment in the progress of knowledge in sepsis. Now they chose JAMA because it's more of a broader read journal rather than a critical care journal. And so the main objective of this huge endeavour that went into the consensus definitions was to differentiate sepsis from uncomplicated infection and to update definitions of sepsis and septic shock to be consistent with what we understand to be the improved understanding of the pathobiology. Now, if you haven't got this paper, you can access it off JAMA, and it's actually open access. It's an interesting read, but it's a very academic exercise and through and actually show you, apply some of it to the clinical practice, which is how we use them in clinical practice. So you can see the new definitions for sepsis and septic shock were the first revisions since 2001 and reflect considerable advances made in the pathophysiology, management and epidemiology of sepsis. And they offer more specificity in describing the life-threatening conditions and are aimed at achieving greater clarity and consistency in how sepsis is diagnosed, reported and treated. So there's some underlying consensus things that the task force came up with. And that one is that sepsis is simply not simply infection plus 2 or more SIRS criteria. It's more complex than that. And that bad infection, when we look at someone who's really sick, essentially it leads to organ dysfunction. So they're the things that they came up with. Now the task force was actually a group of European Society of Intensive Care Medicine specialists and the Society of Critical Care Medicine, and they got together 19 specialists of critical care, infectious disease, surgical and pulmonary specialists, and this was in January 2004. So they had a big group of expert opinion, and some of them were academics and some were clinicians. But they used a lot of data, and it was data that had been historically captured within hospitals about sepsis, which is interesting because it's retrospective, and they had to go up and work out what they were going to use and what they weren't. But they ended up with something like 75,000 patients in each group, which is a really big lot of people to look at to be able to work out mortality and the different things that we're going to look at in terms of organ function to be able to work out how we get a definition. So they did it very scientifically, and that way they can sort of guarantee that what they're going to do in terms of definitions meets the criteria of mortality. So let's revisit what the sepsis continuum is, and you can see that infection, of course, and then we had the SIRS response, and then we developed severe sepsis, and that led on to septic shock. Underpinning all this, of course, was the increasing mortality as the patient got sicker. And quite a lot of overlap between infection, sepsis and severe sepsis, and where systemic inflammatory response actually fitted into it. So why was it done? If you have a look back at the old 1991 and 2001 definitions, they were very based on the SIRS criteria. They had the term severe sepsis. But different criteria yielded different results, and things weren't set in concrete or firm. They were very grey in terms of those diagnoses. And what we had is often there was 4 different ways to identify sepsis and 4 different sets of results when it came to mortality. So you'd have different studies reporting different this particular intervention works because we get this wonderful drop in mortality. But in fact, where the underlying issues were the fact that we looked at different ways to identify sepsis. So what we had were inconsistency. So we needed to have consistency so we can actually improve what we do clinically. So SIRS, as we well know, SIRS is an appropriate response to infection, but it also reflects any other stimulus that activates inflammation. And this paper here, this published in 2015, and I'm sorry about all of these papers, but I'll get past that in a minute. But this important paper was actually one of the clinical trials, Australian Clinical Trials Group papers, and it looked at systemic inflammatory response syndrome criteria in defining severe sepsis. And you can see at the bottom that almost half of the patients hospitalised developed SIRS at least once during their ward stay. So the findings suggested that screening ward patients using SIRS criteria for identifying those with sepsis is impractical. And we know that, but yet we tend to use it. So that's why one of these studies were, these diagnostics were looked at. Okay, so different criteria, different results. So we've got a mixture of what mortality from septic shock is around the world, and in Australia we've got that one there of 22%, but in Germany we report 60%, in Netherlands 60%. So it goes on that in fact not just was it showing different practices, but it also was showing different ways of measuring septic shock. So we needed to become consistent. There were also different ways of looking what hypertension was, what fluid resuscitation was, what lactate measures, base deficits, whether we used inotropes or vasopressors or vasoactive agents, whether or not we defined organ dysfunction by Apache 2, Apache 3 or SOFA. So as you can see, there's very little consistency in the old definition. So let's have a look at inflammatory response. And I'll just show you this little video because just to remind you of what SIRS is. And we've got a finger that has a splinter in it, and it stays there for a few days and becomes nice and putrid. And we have bacteria developing. At the end of it, introduces bacteria into the interstitial space, and we get the immune response with the white blood cells. And in fact, we have macrophages there, which are the white blood cells from neutrophils that have developed into the interstitium. Now, we've got bacteria there, but that may as well be a dead cell from ischemia. It may be something from trauma. It may be something from a burn. And there we have endotoxin released from the bacteria. And as the macrophage engulfs it, it produces a little fragment of bacterium on the receptors on the outside of the macrophage, and that moves over to the other macrophage, and you can see little purple vesicles moving out there. They're the cytokines, and of course cytokines are one of the inflammatory mediators and sends messages around the whole body that an inflammatory process is happening. So the cytokine sits on the receptor of the macrophage, and they start to all congregate around the area that either you have bacteria or you may have dead cells from trauma or ischemia or burns. But in fact, the pattern recognition is the same as it is for bacteria. So that's why we get a SIRS response to several things. And here at the moment we have a localized infection, but for it to become systemic, it needs to move through the lymph system, and we have the lymph system there. And within the lymph system, the macrophages meet up with the T cells and B cells, which are also white blood cells that have been through the thymus and the blood. And we come to the lymph nodes, and here the macrophages meet up with the T cells, and they meet where they have their receptor sites, and they join up and send off the messages to the T cells, and they then send off this approach where they divide and multiply, and they set off more inflammatory response messengers through cytokine release, and then they become more systemic because then they flow through the blood system. And a lot of what we see with inflammatory response comes from the cytokines. So we have a body response to infection or to a stimulus of some sort, and then we get massive cytokine release, which then leads to histamine release and a lot of other inflammatory response mediators to give us the inflammatory response. So then we have, if we have a look at SIRS, the symptom of all that is a fever, of course, or even being quite cold in people who are immunosuppressed. We have a heart rate which is increased, respiratory rate which is increased. Your PaCO2 is decreased because of your hyperventilation, and a normal white blood cell count, where in the majority of us it would be an increase in white blood cell count, or those that are immunosuppressed, of course, a reduction. So SIRS is non-specific and can be caused by ischemia, inflammation, trauma, infection, or several insults combined. Thus, SIRS is not always related to infection. And of course, that is one of the main underlying reasons for why these definitions have been changed. So if we look at the previous sepsis continuum, we take out the inflammatory response, we then need to take out severe sepsis as well, because that is what led to it. And we are left with the term sepsis. But in fact, what it does, it simplifies the process. And most people find severe sepsis confusing anyway, and the terminology of sepsis is often meaning severe sepsis. So again, that simplifies the process. But then we need to replace the systemic inflammatory response criteria with something else. So the possible way of looking at that is the adaptive nature of organ dysfunction. And in fact, sepsis is more than just inflammation that's gone a little bit rampant. There's a lot more of immunosuppressed patients these days with chronic disease. There's a lot of non-immune mechanisms involved, and this also reappraises the nature of septic shock. So if we look then at the new definitions, we have sepsis. And sepsis is defined then as a life-threatening organ dysfunction caused by dysregulated host response to infection. It involves organ dysfunction, indicating a pathobiology more complex than infection, plus an accompanying inflammatory response alone. So sepsis now is the old severe sepsis. We've got rid of severe sepsis and replaced it just with sepsis. And we don't call it a regulated host response, because often the regulated host response is to so many various things that it's more a dysregulated host response to infection, because it leads to organ failure. So organ failure and organ dysfunction, which we're familiar with in the critical care area, can be measured various ways, but they've used what's called the SOFA score. And the SOFA score looks like this. I think the first thing with the SOFA score is, first of all, you've got points across the top, and then down the sides you have various organs. They don't have skin there, which is interesting, but you can also look at skin for mottling and things like that, which is probably more related to nursing care. But what you mainly can see is that we really need invasive stuff. We need to take bloods, we need to do blood gases, we need to probably be giving vasoactive agents to be able to measure the SOFA score. So that makes it very tricky to do if you're using it in the ward or if you're using it in the emergency department. How do you pick whether or not someone has a change in their SOFA score by 2 points, which is the criteria? So what they've come up with is a screening tool called the Quick SOFA or the Q SOFA. So this particular screening tool is going to be used instead of the SIRS criteria. It's still very similar. We still have hypertension or systolic blood pressure less than or equal to 100 millimeters of mercury. We still have altered mental status and often an early change in that. We still have tachypnea and a respiratory rate greater than 22, but they've decided on 22 not simply because someone decided it was the appropriate number. They've actually looked at the cohort of patients that I showed you earlier, the 70-odd thousand patients, and looked at organ failure and matched it to the respiratory rate. So it's been done in a very big cohort of patients and come up with a number that has actually been validated properly. That doesn't mean, though, if your patient's looking awful and they've only got a respiratory rate of 20, that you discount them. But it gives you an idea of progression. So the presence of at least 2 of these criteria strongly predict the likelihood of poor outcome in out-of-intensive care patients with a clinical suspicion of sepsis. So you can use this in the ward. You can use this in the ED. In fact, you can use it in your patients who are spontaneously ventilating and who are awake, even in the high dependency or the ICU. And so it does have an easy and quick, and that's why it's called Quick SOFA. So further to this is the new definition for septic shock. And we have the definitions there. First of all, it's defined as a subset of sepsis in which underlying circulatory and cellular metabolism abnormalities are profound enough to substantially increase mortality. So it's associated with mortality. But the criteria is that you need to have sepsis, you need to have some form of vasopressor therapy happening to elevate your mean arterial pressure greater than 65 millimeters of mercury. And running alongside that, you need to have a lactate greater than 2 millimoles of litre, despite adequate fluid resuscitation. So that's not a lot different, I suppose. We've still got sepsis. We still have vasopressor therapy. You can see that we need to elevate the mean arterial pressure. That makes sense. But the lactate's a bit different because if you recall, we used to look at lactate greater than 4 millimoles per litre. Now, what adequate fluid resuscitation means is still debatable. And even though the surviving sepsis guidelines go from 20 to 30 mils per kilo in their initial fluid resuscitation, you'll see that this area is under debate. So what tangibly differentiates septic shock from sepsis? It's the mortality. So septic shock is really bad sepsis. So your sick patient that needs inotropes, that's starting to have elevated lactate, despite having some fluid boluses, that's still to be quantified. They certainly have organ dysfunction because they have sepsis. So that's what septic shock looks like now. And here is the flowchart that we use to identify sepsis. So this is in the publication, and you can see, I'll just get my pointer pen and go through this. So you have your patient with suspected infection. The thing is, though, that hasn't changed, has it? We still rely on our tools to be able to identify suspected infection. We then use our Q-SOFA. Is our Q-SOFA greater than 2? And if it isn't, then you sit on them for a while and still suspect sepsis. Or if they do meet the criteria for your Q-SOFA score, you can then assess evidence of organ dysfunction, and you need to do that by doing some bloods, some investigations, some blood gases, some different things like that, and then confirm that you do have organ dysfunction. And if you don't, then you need to watch them still again. Further on, if they are confirmed to have organ dysfunction greater than or equal to 2, an increase in 2, then you actually have your diagnosis of sepsis. To be able to go from sepsis to septic shock, we then have this criteria here. We're on vasopressors that are required to maintain mean arterial pressure greater than or equal to 65 millimeters of mercury, and that's despite adequate fluid resuscitation. And then we bring in the serum lactate, which I'd like to speak to about in a sec, and that will lead to septic shock. We'll apply this in a minute to a patient, but for now I just want to talk a little bit more about the definitions and ICD coding. And this table here shows us the definitions we've just talked about. There's the definitions there, and then we have the clinical criteria here, as we've just mentioned. But down here, and this might not seem of relevance to our clinical practice, but the ICD 9 and 10 codes are actually important for hospitals to actually code sepsis properly. And in the past, we haven't been able to do that. So the actual money that hospitals get for severity of illness and different types of diagnoses is reduced because sepsis doesn't come across as severe as much as it is. It costs a lot more to look after a sepsis patient than what they're actually funded for. So that will improve that process and allow us to look after our patients. We have better funding for it. But further on, I was talking to you about that the Global Sepsis Alliance is wanting to do the burden of disease with the World Health Organization. Until these codes are actually correct, we can't actually do an adequate burden of disease. So that's important. It's really, really sort of bigger picture primary health care. And lactate, I want to talk to you quickly about this, and I apologise for the statistics here, but they explain it nicely in terms of a curve. So we have a graph here, and on this graph we've got sensitivity and specificity, and this is used for diagnosis. So what's important though is you can see that the black line here is a baseline risk assessment for someone with sepsis, and if you add the Q-SOFA, then the ability to predict how quickly or their risk of death is in the red there with the Q-SOFA. So, sorry, no, the Q-SOFA is the light brown. But if you add lactate to it, you can see that it just superimposes it. And lactate these days in sepsis is not seen so much as a something that is a marker of shock, but more of a marker of metabolic stress that goes along with shock. So they've decided to use it as an accompanying diagnostic rather than something that's part of the definition. And they looked at a lot of patients with lactate and sepsis, as they did earlier. So in fact, what we have is the addition of lactate did not meaningfully improve prediction of Q-SOFA, but it does help us identify people at immediate risk who are under metabolic stress. And you can see here that if you have that we have hospital mortality at the top and different levels there, but if we have hypertension and we have a lactate greater than 2, the predicted hospital mortality is higher than no hypertension and lactate less than 2. So they've done all the actual predictions of what lactate is worth, and that's, in a sense, why they've come up with hypertension and hyperlactemia for the septic shock diagnostic. Okay, so let's then apply this, and I've used the sepsis pathway, which is used by the Clinical Excellence Commission in New South Wales, because it's a really good standard one. And we have a classic sepsis case. 82-year-old female presents to the ED. She lives alone at home. She's had a fall. She's found by her housekeeper. She's agitated and disorientated, which is a new state of consciousness. She's incontinent, and that's quite odorous. Her temp's 35.6, heart rate's 102 and irregular, respiratory rate's 26, shallow breaths, a history of ischemic heart disease. So let's have a little look at how we would classify this patient in looking at the SIRS criteria. So if we bring this up here, first of all, recognising infection hasn't changed. We still have risk factors or signs and symptoms of infection which haven't changed. We have immunocompromised chronic illness, and often that's the case in the elderly. And in her we have a fall not related to mechanism of injury. We have breathlessness, we have new onset of confusion, altered loss of consciousness, etc. We also have dysuria and frequency and odour. So those, we certainly have signs and symptoms of infection, and she's over 65, so we need to take into account that many of her signs and symptoms have been blunted because the immune system doesn't react quite as well. So let's look at the old SIRS criteria. And in fact, she would meet 3 of those criteria quite well, and which then would probably go on to activate the sepsis pathway. But and over here, if she had an increased lactate, that would then go on to look at septic shock. So in fact, that hasn't changed a great deal. But what has changed is that, and I'll just bring up the next slide, is that the sepsis pathway hasn't changed a great deal. And we still have to do the resuscitation and reassess. That hasn't changed. We still have to do the A, B, C, D, E, F, G, monitor and reassess, referral if we need to. We still need to maintain the airway, give oxygen if they require it. Do bloods, okay. Do the resuscitation even though that may change in fluids soon, okay. antibiotic administration is still important. We still need to assess the level of consciousness using alert voice pain unresponsiveness or less conducted GCS. We need to look for looking for a source of sepsis. Investigations involved there. We need to do their fluid balance and be careful that what they're doing in terms of fluid in matches fluid out. Blood glucose, and then we continue on and we monitor and reassess. And then we can go on and do the sepsis 48-hour management plan. So that hasn't changed. But if we perhaps look at this lady and use the Q SOFA, we can see that she has hypertension. So no, we actually haven't. We've got altered mental status, so we have that there. And we have tachypnea. But if we did her blood pressure, we would probably find that it was probably on the lower end of normal because she has these other signs and symptoms. So we would suspect, first of all, we would still need to use the old infection toolkit before we moved on to the Q SOFA. So we have a score of greater or equal to 2, and then we would need to do bloods for organ dysfunction. Then we'd be able to work out whether or not we had a proper SOFA score. And of course, all of this needs to be done with all the vital signs and working out exactly where we are, because we've only got some very baseline signs and symptoms there. So certainly she would have sepsis, and then we would be able to see what her blood pressure was and her serum lactate to see if she actually had septic shock. But we need to keep in mind that the elderly often have septic shock, but we don't see that in their vitals until we measure their serum lactate. Okay, so that, in a sense, would be the only part that would be needed to be replaced back here in this area, is that we would have to put in a quick SOFA, and then we would have to get rid of, and see, we've got sepsis there, we've got severe sepsis there, so again we would just have to have 2 instead of, it'd be simplified considerably, the pathway. And here we have our SOFA score, which we can work out from our bloods, and we'd be able to proceed with resuscitation. So the nursing role in this is to continue to use the recognising infection tools, learn your Q SOFA, and you may want to find somewhere, and if you go to Google and look for Q SOFA, there are plenty of images of the little sofa with the vital signs on it, and you can print out some posters and put them up. And I know that the the excellence, safety and quality will actually print out quite a few of these quick SOFA things for you to put up, posters and things like that. They're being developed right now. Now, if your Q SOFA is positive, and really use your common sense, if your patient looks sick, continue the sepsis pathway, ensuring bloods have been taken to confirm SOFA score, because sometimes patients compensate, don't they? And you'll find that the sicker they are, quite often the compensation is higher, especially in the younger person. Some main points: we should be looking for organ dysfunction every time we suspect infection. But on the other hand, we also need to be looking for infection whenever a patient presents with organ dysfunction. And then we continue to resuscitation and reassess in your ABCs, etc. But don't forget that SIRS is still part of the process in deterioration, and that it still has a place in what we look at in terms of whether a patient is considered sick or not. Now, there's been lots of debate, and these are some of the issues, even though the task force thought they were probably quite relevant. Sepsis 3 did not involve low or middle income countries, where raising awareness and early detection are priorities. So patients with isolated hypertension or a reduced level of consciousness will be classified as uncomplicated infection. So very, very tricky. When they looked at QSOFA, they looked at retrospective patient cases, and there may have been a lot of error in that. So it's still to be validated in prospective patients. Apparently, it's been endorsed by ANZICS in Australia and New Zealand. It's also been endorsed by the World Federation of Critical Care Nurses. But the task force didn't involve the College of Intensive Care Medicine or the Australian College of Emergency Medicine. So not sure if it was the clinical trials group that endorsed it, because they did that big paper on SIRS. Okay, but still, the performance of QSOFA for mortality prediction is similar to the SIRS criteria. The only thing is with the SIRS criteria is that we don't have anywhere further to go with that. It stops at that. Whereas with the QSOFA, we can look then at deterioration in regard to organ failure, and we take bloods, and we can have some form of diagnostic with it. So the Global Sepsis Alliance, we reviewed it as well, and here are the reports. They also, they actually think it's a great thing. They're really pleased it's happened. They strongly encourage prospective validation in multiple health settings to confirm its robustness and potential. So in other words, keep looking at it, keep testing it. Remember, QSOFA and SOFA isn't to be a standalone definition of sepsis. So it means that if you've got a sick patient, don't delay, don't defer, or don't stop treating or looking at them just because your QSOFA isn't adding up to what it should. Okay? Use your common sense, use your experience. SIRS criteria is still useful for the identification of infection, and if you're familiar with it, certainly use it with conjunction with your QSOFA. There's certainly you can't lose. So that, in a sense, brings us to the summary. And SIRS is no longer a criterion for sepsis. It's been replaced with quick sequential organ failure assessment, or the QSOFA score. It's now used to clinically characterise sepsis patients, and we've lost the severe sepsis title. Lactate's now part of the septic shock criteria, along with resistant hypertension. Okay, so I'm going to stop it there and return to everybody. And I will ask you now for your questions. And just reminding you now that we've got World Sepsis Day on the 13th of September of this year. So thank you for your attention. And if you've got some questions, I would welcome them.